retinal fluid that can develop. And certainly in non-neovascular AMD, OCTA can be an invaluable tool to help you determine if neovascularization is present or not. And in the absence of neovascularization, I think you may be more inclined to attribute that subretinal fluid to a transudative or non-neovascular pathway.
So one question from our audience is, let's just say, for the sake of argument, you didn't recognize that this is non-neovascular AMD, and you see some transudative fluid, and you treat it with anti-VEGF. Would you expect anti-VEGF to cause this fluid to resolve, or would you expect anti-VEGF to do nothing to this fluid?
Yeah, that's another good question. I mean, certainly, in my experience, there can be a response. We know that VEGF is an antipermeable factor. That's what it was initially referred to as. While there may be a response, there can be in other situations, though, I think a poor improvement in the fluid. So I think it's variable, but I don't think you see typically the brisk improvement that you see with neovascular fluid. But I believe there can be a response. So the empirically treating with anti-VEGF, I don't think will always give you the answer. Even the degenerative cysts, I've seen some response of that degenerative cystic pathway to anti-VEGF. So it doesn't always give you the answer.
David, it's Mauricio. I have a question. First, this is a very, very beautiful, wonderful case series, 74 cases. And you show that subretinal fluid is related to the compensation of RPE or the RPE pump failure, right? So this is related to drusen or drusenoid PED. So we should not treat. You have an idea which case, how this is the percentage of cases that may migrate to the neovascular form, and any idea for the biomarkers of this and the a protocol to follow this special kind of patients?
Yeah, that's a great question. Of course, this was a retrospective study. I think we didn't determine the incidence of fluid in the non-neovascular form of AMD. That's a question we hope to answer with future prospective trials. It's a very important question. I don't think it's very common. You do see a vitelliform lesions associated with fluid in certain cases, and that may not be as unusual. In my experience, it's a significant minority of cases of neovascular AMD that have fluid, but it's not that unusual a situation. I think, as I mentioned, that there can be other biomarkers of atrophy that can also be present and can be a clue that you're dealing with a non-neovascular situation and a situation that is high risk for the development of atrophy, such as intraretinal hyperreflective foci or areas of choroidal hypertransmission.
Thank you so much. I've seen your background, your hockey guys there, and I look forward to meeting you on a hockey rink in the very near future. Thank you so much for a great lecture.
Thank you very much, Peter. Appreciate that.
Our next speaker is Ashish Sharma, who's going to talk about neovascular macular degeneration and fluid.
For giving me this opportunity, and it's such an honor to be here with all my teachers, all my mentors who are sitting down there. So I would be more of learning rather than talking. So my topic is neovascular AMD and fluid, and these are my disclosures. So fluid has been closely associated with the neovascular AMD, and whether it's terms of the diagnosis or treatment or retreatment decisions, fluid has played a very important part. And fluid accumulation, none of us like, because that has been considered as the most important aspect as an indicator of the disease activity. And if you look at the last decade, majority of the trials were dependent on the fluid in terms of their treatment decisions, multiple various forms of the treatment strategies. And for example, CAT data shows that fluid was present in multiple compartments, SRF, IRF, and sub-RPE fluid. We have had wonderful modalities of imaging as far as AMD is concerned, but if you just look at the fluid, I think OCT has really played an important role as far as our day-to-day practice is concerned, and OCT has played an important role in our treatment decisions in terms of day-to-day clinical practice. And OCTs has also advanced, and as of now, most of us use a spectral domain or swap source OCT. Over the time, there is buzz on the home page OCT, and there are a few good papers recently published as far as machine learning AI is concerned, that probably over the time, once we have the AI functioning well, we might have a better idea of the volumetric analysis, which might be giving a better answers rather than having the measurement on the OCT scans. So coming back to the fluid, there are three compartments. I think we all know that within the inner retinal layers, IRF, and below the retina and above the RPE, you have a subretinal fluid, and below the RPE and above the basement membrane, that Bruch's membrane, you have the sub-RPE fluid. We call them as a fluid, but it can have multiple components, exudates, hemorrhage, so that all consists as a part of the fluid. I think this was wonderfully covered by Dr. Saraf, and I would definitely like to thank him because I have learned from him so much when we were working on this particular paper on the mechanism of fluid development, and I have personally, so thank you, Dr. Saraf, for that. As far as management of the fluid is concerned, over the time in last 2 decades, with multiple trials and evidences, especially from the CAT and the VIEW, we have come to a kind of understanding that intraretinal fluid was associated at each and every time point with poor visual acuity, and even at the baseline, it was a poor predictor. And in cases of SRF, we have evidences that over the time, if SRF doesn't resolve, probably the persistent SRF is something that can be tolerated. Sub-RP fluid, I think still we need to have more data to conclude anything conclusive. Probably once we have the OCTA with swap source OCTA machines, more and more data coming in, we might have a better point to make here. I would just like to highlight one point as far as subretinal fluid is concerned, coming from the CAT and the VIEW trial. And if we really see the details of both the papers, that SRF could be tolerated, but really looking at the fluid, look at the example, if we type to M and V, where the pathology starts at the choroid and then everything goes up. So IRF probably comes in when you have the destruction or the disruption of the ELM and the photoreceptors. That is why there is a poor prediction whenever you have the IRF on the cards. And as far as the vision is in the outer retina, and then it goes down, and probably in these cases, IRF may not be as bad as you have in the type 1 and the type 2. Although, we do not have the clear answer yet, because most of the trials from where we have the prognostication values coming in, they have not isolated the type 3 cases and identified the data. Probably we might find that answer in near future soon. So to conclude, IRF should not be tolerated. SRF can be tolerated with careful observation of the other signs and the biomarkers. And sub-RP fluid may be tolerated if the visual acuity is good. Probably it can help in avoiding the GA progression. And further OCT biomarkers are needed for better characterization of the non-exudative versus exudative fluid, especially in the non-exudative area. And once we have more and more AI-based volume analysis, probably we have more knowledge about the fluid and understanding the fluid. Once again, thank you so much, RWC, and all the teachers who are here. I'm honored. Thank you so much.
Thank you, Ashish. That's a great talk. So we're going to open it up to our panelists, and you presented a lot of data on fluid. I wonder if one of our panelists can talk about this. I know, Roberto, you're involved in a lot of artificial intelligence and fluid analyses. Do you want to comment a little bit on your take on some of the comments that Dr. Sharma made in this talk?
Well, thank you, Richard. That was a wonderful presentation. And I always miss one particular point when talking about subretinal fluid, which is the differentiation of the neovascular phenotype associated with that particular subretinal fluid. As we all know, long-standing subretinal fluid, those particular patients that we cannot get rid of the fluid in them, are associated with type 1 lesions mostly. So there is, in my opinion, an incorrect syllogism of presence of subretinal fluid, patients doing good in the long term in terms of visual acuity, because they have a type 1 neovascularization, which is the real cause of that retention of good visual acuity. And as Ashish perfectly said, there's a lot to do yet, but we may not forget the phenotyping of the particular neovascular lesion underlying that particular fluid that we are analyzing. And that's a challenge in terms of artificial intelligence also.
Any other panelists want to comment? Alan, have you had much experience, kind of looking at this fluid and tolerating fluid? In your estimation, what do you look for when you leave fluid on the table, if you had to leave fluid at all?
I think it's become very clear that where the fluid is matters for patients over time. In clinical experience, and most recently, I think the most powerful paper that we should all be aware of is the Robin Geimer fluid paper with the treat and extend model, where they randomized patients and looked at the tolerance of intraretinal or subretinal fluid. And subretinal fluid is compatible with ongoing good vision. Intraretinal fluid is more destructive. I think from clinical take-home points, that's important. I will be a little less aggressive in 2020 with subretinal fluid in terms of interval and frequency, and more aggressive when I see intraretinal fluid. I think David Saraf's talk was once again excellent. And that particular phenotype that he mentioned briefly at the end of the vitelliform phenotype of dry macular degeneration is an important one, because you can see persistent fluid there that may not represent neovascularization. In fact, when we were doing fluorescein angiograms a lot, it would be a pseudo hyperfluorescence and pseudo CNV that's there. You can get choroidal neovascularization there in anti-VEGF responsiveness, but be aware that vitelliform lesion may trick you into thinking that there's leakage.
Wonderful.
Yes, actually, I have a question to Ashish. Ashish, I think one important point is not to undertreat cases with active neovascularization, because there are a lot of publications that shows vision loss when we do that. So any tricks that you could give us in order to avoid undertreat the patients with active neovascularization and subretinal fluid?
I think the papers, as Dr. Allen told, that, at max, what you can do is, if you have a persistent SRF, that you can wait and watch. I think that is the only way that you can have a kind of a balance of reducing the injection in the real world scenario. That's what we do, because we have all the patients who are paying from their pocket. So really, we are not really aggressive in treating them.
Okay.
I have one question. You are the leader of this field, and I'm working for the home-based OCT and artificial intelligence company. And the new machine can differentiate either SRF or eye alloys, which we should focus on for general use. in the US, Europe? SRF or IRF?
I'm sorry, question to me or?
Oh, anybody.
I think Dr. Anat was the one. I think she was working on this, especially in the home-based OCT. And the AI had Dr. Uja, I think Dr. Ursula, she was the one who had published the first paper in terms of the AI-based evaluation with the Hawk and Harriet data. So I think that was the paper which I was mentioning.
Yeah, in the essence of time, we're going to move on. Thank you for your comments. Next talk will be by Francesco Bendello. Francesco, you have the most enviable background of any of us. I don't know how many bottles of wine that might be behind you, but we're all very envious of that. And you're going to talk about brolucizumab and intraocular inflammation.
Thank you. Thank you so much for allowing me to take part in this session. These are my disclosures. I like to start this presentation with this slide, which is, I think, the best slide produced during these last years. This is a paper published by the group of Michael Larsen, where you can see that the number of patients with visual loss secondary to age-related macular degeneration decreased significantly during the same years corresponding to the introduction of anti-VEGF approach to wet AMD. So this reduction is important because it's the evidence that we are now doing a lot for our patients. I'm not sure that there are other specialties where you can show something like that, an important result like that. If you look at the visual loss, generally speaking, you see that the numbers are more or less the same, but starting from 2004, 2005, when anti-VEGF approach was introduced in clinical practice, we had this significant reduction. This is something important to be remembered and to be stressed with our administrators, with our politicians, because they need to understand that we are really in a condition to modify the incidence of visual loss. So, you know that we have today these different anti-VEGF drugs. We start from bevacizumab, aflibercept, ranibizumab. I do not want to spend time explaining you what they are doing, but looking at the brolucizumab new drug, you see that the molecular weight of this drug is much lower compared with the others, and this is the reason why we have a higher molar concentration, a potential for better diffusion into retinal tissue, and a significant reduced systemic exit and safety. So all the information we have about brolucizumab are coming from these two registration trials. One is the OAK, the other one is the ARIA. And these two trials were conceived in order to compare the efficacy and the safety of brolucizumab compared with aflibercept. Two different dosages of brolucizumab were used in this trial. And the study design was based on 3 monthly injections. And then using brolucizumab, the investigators were allowed to dose your brolucizumab injections each 3 months, or coming back to less intervals. And the aflibercept arm was treated always with monthly, 3 monthly injections and then bi-monthly. So the results of the study are here summarized. As you can see, the primary endpoint, which was the non-inferiority trials, was that the two different dosages of brolucizumab were able to guarantee the same level of efficacy compared with the aflibercept. And this was true in both the trials. And looking at the different secondary endpoint, there was an evidence that all these different secondary endpoints were better with brolucizumab compared with aflibercept. So the disease activity, the intraretinal fluid, and the subretinal, sub-RPE and subretinal fluids were better with brolucizumab compared with aflibercept. But, you know, the point is that, unfortunately, we had some evidence that these are a lot of trials, as you can see here. Ashish was speaking before me, and these are the papers published by Ashish during this last month about this topic. Ashish is a very productive author and is really an expert with reference to the brolucizumab therapy. So, with reference to the efficacy of brolucizumab, we can say on the basis of the data that we have a similar best-corrected visual acuity when we compare brolucizumab with aflibercept, but with better anatomic results. And the other point is that we can extend the dosing regimen to 12 weeks, which means 3 months. And this means that we should have a potential reduction in the burden of treatment for our patients. Then we had a better control of intraretinal fluid with brolucizumab. We had some other advantages. In fact, the FDA-approved dosing regimen, 3 monthly loading dose, and then Q8, so 2 or 3 months between the different injections. So potentially we can have 2 fewer injections compared with aflibercept, and potentially 6 fewer injections compared with ranibizumab. But unfortunately, as I was saying before, there is a higher incidence of intraocular inflammation. Most uveitis and iritis cases were mild, moderate, and treated only with topical steroids. But the American Society of Retina Specialists during the 2020, February and March, produced a document in order to make some kind of alert among the eye doctors community about the use of these drugs because of the risk to have some kind of intraocular inflammation. So at the moment, we are still not able to know which is the real reason why this kind of drugs is responsible for this higher number of complications. This is a paper by Caroline Baumal, and this is a paper where 15 non-naive cases of 12 patients affected by this kind of inflammation after brolucizumab were very deeply considered. And the data are here. All these patients were women, first of all. The mean number of injections was very high, 27.5. All patients had at least one of the typical symptoms: floaters, scotoma, ocular discomfort, and retinal vasculitis and intraocular inflammation were diagnosed and on an average of 30 days. So the first important information is that, so be careful, women, be careful 1 month after injection, you must be really very careful. All eyes showed the vitreous cells, opacities, and most had anterior chamber cells. So with reference to the posterior pole, there was an occlusion of the larger retinal arteries, delayed retinal arterial filling or occlusive vasculitis, and perivenular sheathing associated with leakage. Here you have a typical aspect of this kind of lesion. It's a very impressive angiographic appearance. You have this disappearance of vessels, which is really something which is able to produce an important effect. So this is another case where you see that there was this occlusion of vessels, but after 1 week of steroids orally prescribed, there was some kind of improvement in the appearance of the angiographic lesions. So what we can say on the basis of the Caroline paper, we have first a prompt recognition of this kind of complication is absolutely needed. A differential diagnosis must consider other causes of uveitis, endophthalmitis, embolic causes of retinal artery occlusion. The clinical examination before repeating intravitreal brolucizumab must be done in order to avoid other injections. And the nature of this complication is progressive, and therefore a close follow-up is required. In these cases, fluorescein angiography is absolutely important in order to understand what is going on with your patients. And visual acuity outcomes are strictly related to location and severity of the occlusions. So these are my conclusions. I am absolutely convinced that brolucizumab appears to represent an incremental improvement compared with the other anti-VEGF approaches we have today, and specifically with aflibercept, consider that it was the anti-VEGF drug compared with brolucizumab in the two trials. The longer duration of action for sure may alleviate the problem of undertreatment without compromising efficacy. The risk of occlusive vasculitis may have an impact on its use until more real-life data are provided. So on the basis of the data available today, we can say that brolucizumab must be avoided in the presence of active inflammation in cases in which brolucizumab-led inflammation is noticed. And this patient must be closely followed because occlusive vasculitis may present late in the history. So thank you very much for your attention. Thank you.
Thank you, Francisco. This is a very interesting problem. Obviously, it wasn't seen, in particular, retinal vasculitis and retinal occlusive vasculitis really wasn't reported in the Hawk and Harrier original results. The Safety Review Committee has since changed the label to include retinal vasculitis, retinal occlusive vasculitis. But I have a question for Alan. Alan, we've had brolucizumab now for almost a year, over a year actually. In what patients, given what Francisco just showed us, do you use this product, and what are some of the tips and tricks you can share with our audience?
Well, it is an interesting question, and the idea of raising the bar for drying patients out and for reducing treatment burden with extension are really important issues. However, I'm not using this medication right now. My problem is that I can't predict. I mean, there are certain risk factors that I think are important, that is uveitis in the past, but I can't get through the informed consent of this particular medication at this time with patients. In fact, in some of our clinical trial patients, after reviewing the new data, many of them have opted to come out of the trial. I think this is an interesting phenomenon, and we would all like to see a more durable anti-VEGF, but right now the safety bar is so high with ranibizumab, aflibercept, and bevacizumab off-label that I can't use this right now.
So, Francisco, I know Novartis has convened both a safety review committee and a think tank to see if they can come up with the root cause and some mitigating strategies. And I know one of the findings from the think tank was looking at the IRIS and Komodo databases, so thousands of injections, and two things really stood out. One you mentioned, which is the female gender. The other is this idea that if you had a previous history of either local uveitis or systemic inflammatory diseases, those patients also had a higher risk. Alan said he doesn't use it. I'm curious to hear what you do with brolucizumab. Do you use it, and what is the discussion you have with patients?
I must say, we started to have it available in Italy since a few weeks only. And I'm not able to say which is my attitude, because we are really starting now. And at the moment, the drug is not reimbursed. So really, we have not a good experience about that. And for sure, I need to do my own experience in order to answer your question, which is, I think, the most important problem: when to use it, when and why. My feeling is that I will try to use it whenever all the other anti-VEGF approaches are not working. I mean, whenever you have fluid still there, the patient is not sensitive to the other approaches, those are the cases where I think I will try to use it. I know very well that in these kind of cases, if you have one bad experience, maybe Alan had something like that, you lose your interest about the drug. And that's the story. I mean, whenever you have a complicated case, you lose your interest about a choice like that. I see. I mean, I'm not able to answer your question. I'm sorry for that, but I need. I will try to use it in complicated cases, hoping that I will not have the same kind of complication issue.
And Francesco, Alan, and Peter, do you know the risk factor that Francesco didn't tell? It is Japanese. We had a lot of cases.
I didn't know that.
2 CLAO cases in my first 5 patients. 2 cases.
Yeah.
Yes, please.
Important observations. Let me just say this about this particular drug. We need a longer acting drug. Novartis has been incredibly transparent in their independent safety review committee process. The idea of gender being a risk factor, I think now has been shown that females do not have a preponderance of this after looking at more of the data. There are some patients, and I have colleagues who continue patients on this medication even after discussing the risks, the increased risks. And I respect that because those patients can make those choices understanding the latest safety information. I personally I'm not in that situation right now, so I haven't been using it. But for those that want to use it, I'm not judging them in that way. Because if their patients understand the risks, maybe they were having, trouble with the other therapies. So Novartis has really done a good job. I'm looking forward to hopefully a better formulation that mitigates this issue.
Do you think
I have a question to all the panelists, and especially Francesco. Based on the Hawk and Harrier results and your personal experience, do you guys think we need a special informed consent form when we do this kind of treatment in order to minimize the legal problems?
I would say yes. I mean, there's no question.
Agreed.
Yes.
That's mandatory, Mauricio. And actually, all the recruitment for the clinical trials in Spain were completely stopped until we got the specific informed consent. So I think that's key for patients and for ourselves.
Agreed.
And one of the things that the think tank has really found that is related to this is the presence of neutralizing antibody. And unfortunately, this is not a test that any of us have in our clinics or even locally to be able to perform. But the majority of these cases, at least in Hawk and Harrier, where we have this data, was related to neutralizing antibody. And what will be very interesting is to see Kite, Kestrel, some of these other studies that are coming out very shortly, which also will have neutralizing antibody data behind it to see really what type of correlation that is. And then obviously Novartis will have to hopefully come up with a way for us to test this because there's obviously no way to do that. So I think go ahead.
Just worth noting, Francesco, you mentioned this is an incremental improvement. I think what we found and why we're not abandoning this entirely because of these safety concerns is that the efficacy was impressive. We were able to take patients that were not responding to other compounds, and they did respond here. That's why we're still somewhat invested in trying to sort our way through this because the efficacy was impressive. So again, I think if the safety hadn't been a concern, we'd all be happily using it as potentially transitioning to it as our lead drug. Who knows?
Well, I agree with Barry. I use this drug, and there are patients who benefit from it. And the patients who benefit are patients, for instance, who are on aflibercept every month and are either having increasing fluid, decreasing vision, and then, as we talked about before, we have a very involved, informed consent. We look very carefully at these patients each and every time they come in. But they do. This drug works. It's a great drying agent in those patients. So I don't think it's a do not use drug. I think it's a use carefully drug. And unfortunately, until we have some more mitigating strategies, we kind of have to relegate it to third line at this point. So for sake of time, we'll move on. The next speaker is Dante Pieramici. Dante is going to speak to us about the port delivery system with ranibizumab.
Thank you, Peter. It's good morning, good afternoon, good evening. Francesco, looks like you're going to have some wine now, so enjoy. I'm going to give you a little update on
I had it.
You had it already? Great. Have some champagne then. I'm going to have some coffee, but I'm going to update you a little bit on the port delivery system with ranibizumab, and certainly this is a device being developed by Roche Genentech. The port delivery system is a permanent, refillable intraocular implant that comes with a customized formulation of ranibizumab. We can place it surgically in an outpatient procedure, and it can be refilled multiple times in the operating room. It really is a platform technology and can be used with other drugs in the future. The latter was a phase 2 clinical trial that looked at the port delivery system at various dosages and compared it with monthly intravitreal ranibizumab injections. They found similar outcomes in visual acuity and anatomical outcomes compared to monthly intravitreal injections in the high dose group. But the primary outcome of this study was the time to first refill, and 80% of the patients in the high dose PDS arm could go 6 months or more without needing a refill. And the median time was fairly impressive at 16 months. Because of these positive results of the phase 2 clinical trial, the Archway phase 3 clinical trial was developed. I also wanted to mention here that during the latter trial, pharmacokinetic data was also obtained from the anterior chamber and serum, and it correlated very, very well. And you could find measurable serum levels out past 16 months. So that brings us to the Archway trial, and this was a phase 3 clinical trial designed to test the high-dose PDS, 100 milligrams per ml, mandated refilled every 6 months versus the standard of care, which is intravitreal ranibizumab injections on a monthly basis. The primary objective of this trial was to evaluate for non-inferiority and equivalence of the PDS refilled every 24 weeks versus intravitreal injections on a monthly basis. The primary endpoint of this study was a change in best corrected visual acuity score from baseline to an average over weeks 36 to 40. Patients in the PDS arm could get rescue therapy if criteria was met. The baseline characteristics and demographics were very well balanced between the arms and fairly typical for what we see in AMD-type trials. I would emphasize that these are not patients naive to anti-VEGF agents and on average had 5 previous anti-VEGF injections and had a diagnosis of neovascular AMD for about 6 months. The study retention was excellent at 98%, and there was no impact from the COVID-19 virus. This is the primary outcome in the port delivery system. Refilled every 24 weeks was non-inferior and equivalent to monthly ranibizumab injections, as you can see in the figure below. Visual acuity outcomes were almost identical between the PDS and intravitreal injection arms. Remember that these patients had been previously treated. So at baseline, the visual acuities were excellent at 20/32, and this was maintained to weeks 36 to 40. There was a slight decrease in visual acuity in the surgical arm, and this is expected in a post-operative eye, and it returned to baseline within about 8 weeks. OCT thicknesses, again, were identical between the PDS arm and the monthly ranibizumab arm, as you can see in the figure here. 98% of the PDS patients did not require any supplemental rescue therapy. So if we look at the burden of therapy, if we consider the initial fill of the PDS device, any subsequent rescue therapies, and the refill at 24 weeks, on average, patients needed 2 treatments. Compare this with a monthly intravitreal arm, they needed 10.7 treatments, so a 5 times fewer burden of therapy. Now, we also asked the patients in the PDS arm, did they prefer the PDS or the intravitreal injections? This is a questionnaire that was given at week 40. 93% of the patients preferred the PVS over intravitreal injections. About 6% of the patients had no preference, and only 1% of the patients preferred injections. These are fairly strong preferences for the PDS in this arm, and the reasons for their preference was that there were fewer treatments, it was less discomfortable for them, and there was less worry or nervousness. Now, ocular adverse events are certainly something we need to look at in a surgical technique, and these are the ocular adverse events of special interest. Conjunctival blebbing, or thickening of the conjunctiva, was seen in 16 cases. Most of this was just thickening of the subconjunctival space. There was one case of a filtering-like bleb, but all resolved spontaneously, and none were considered serious. Vitreous hemorrhages, which were more of a problem early on in the latter trial, that were mitigated with a new surgical technique, were only occurred in 5% of the cases, and they all resolved spontaneously. None of them required vitrectomy surgery. The incidence of cataract development were similar between the intravitreal arm and the PVS arm. Conjunctival erosions or retractions where the implant became exposed occurred in 11 cases. 9 of these were addressed with a flap revision or a partial thickness corneal graft, and were well treated. Endophthalmitis, certainly one of the more worrisome complications, occurred in 4 patients, about over 1% of the cases. 3 of these cases were related to conjunctival retraction. One of the cases was associated with irreversible visual loss, but 3 of the cases, the vision returned to baseline, and 2 of the patients have actually stayed in the study and are continuing to get refills of the implant. There were 2 cases of a retinal detachment that occurred, and these were repaired successfully with vitrectomy surgery. And there was 1 case where the implant became dislocated into the vitreous cavity during a refill procedure. It was successfully retrieved, and the patient is doing well. So if we look at the visual results of these serious ocular adverse events, we can see that in most cases, the majority of the cases, the vision returned to baseline, except for the 1 case of enterococcus fecalis endophthalmitis that occurred. Serious non-ocular adverse events were well balanced between the groups, and none of the serious non-ocular adverse events were related to study treatment. So the archway met its primary endpoint. It appears to be equivalent, the PDS, to monthly ranibizumab injections. We get equivalent vision and equivalent anatomical outcomes. The patients are very happy with this therapy and prefer it in the vast majority of cases. I think it does have a favorable benefit-risk profile. There are certainly some surgical complications that we need to be aware of. We may be able to mitigate many of these these complications with better surgical technique and teachings. So I think that the PDS really has shown that it's maintained vision while reducing the treatment burden through continuous delivery of ranibizumab. So what's next with the port delivery system? Well, the Archway trial continues, and the patients in the Ladder and Archway trial are then being rolled over to the Portal trial, which is a long-term safety and efficacy trial. In addition, for patients with diabetic macular edema and diabetic retinopathy, there are now 2 programs, phase 3 clinical trials that have initiated: the Pagoda trial for diabetic macular edema and the Pavilion trial investigating the port delivery system and the treatment of diabetic retinopathy. Certainly acknowledge all the investigators in the Ladder trial and the Archway trial and going forward. And I appreciate the chance to speak today at this exciting meeting. Thank you very much.
Thank you, Dante. That was a great talk. So I'd love to hear from the panelists. Have you had any trial experience with the port delivery system? And also, Dante, the discussion around that conjunctival bleb, give us a little bit more information what that means clinically. I mean, we see it there, but is it something that we have to worry about with bleb formation, or does it need to be some sort of surgical procedure to fix the bleb issue?
Well, the 1 case of the bleb is probably represents a little leakage around the implant, just like we might see in a trabeculectomy-like procedure. In this case, with time, it resolved on its own. The bleb went away. most of these cases, there's just thickening of the conjunctiva or subconjunctival T nodes in this area right after the surgical procedure. So it looks like it's a little bit elevated over it. But most of these cases resolve as well. I think with the surgical technique, it's very important that we are meticulous about the conjunctiva and T nodes and try to bring both of these tissues up to cover the implant when we do this procedure. We have to be a little bit more like our glaucoma colleagues and really mind the conjunctiva. And I've even gone and gotten special forceps now that are non-tooth forceps to be a little bit more gentle.
Dante, I have a question for you, my friend. PDS is really an amazing idea, and it decreases the burden of treatment, and it's very, very interesting. But my question for you is that, do you have some concerns about the chronic anti-VEGF and patients with previous stroke or heart attack, and also the refill process in different countries and places, actually about the infection rates and endophthalmitis? What do you think about these three situations?
Yeah, I mean, I think certainly the endophthalmitis thing is the part of this that we're most concerned about. I mean, these are relatively high rates, over 1%, and something we don't tolerate with intravitreal injections. But, you know, even if you look back at the early intravitreal injection studies, you see that the rates of endophthalmitis were higher. And it seems like with time and with familiarity with the procedure and mitigation of this, paying more attention to the conjunctiva, we may be able to reduce these risks in the long term. But yeah, I think that this is certainly the thing we want to worry mostly about. We're going to have to continue to monitor these patients. It seems like the endophthalmitis is associated a lot with the retraction of the conjunctiva. So if we see a patient where the conjunctiva looks very thin, it's becoming retracted, and there's exposure, this patient's going to need to go back to the operating room and have this mitigated and fixed at that time. We can't let this be. So yeah, it's going to require, it's not something you're going to just send the patients home and then have them just come back every 6 months for a refill. We're going to need to monitor some way, either home monitoring by monitoring the implant through some sort of video monitoring, or have them come back on a semi-regular basis for photographs or an evaluation. And Mauricio, you had what was the other question? The first one,
actually, the patients with heart attack and also stroke. Yeah. If you feel comfortable to treat these patients with this kind of device, you know.
Yeah. Well, I mean, the nice thing about this device, say, as compared to say a gene therapy, you can always, if say someone does develop a heart attack or stroke, you can always not refill it in the future. So it does give us some flexibility. I don't know. I mean, overall, I haven't been very concerned about heart attack and stroke in most of my anti-VEGF patients. So, but you do bring up the point, this would be a continuous delivery, and this might be different. We haven't seen it, but certainly the numbers of patients that have had this implant now for a long period of time, it's relatively small. But you bring up an interesting point.
Well, that's a great transition to our next talk, actually. So thank you, Dante. And we're going to hear from Praveen Dugal now, talking about gene therapy for neovascular AMD. Praveen?
Rishi, thank you. This is a great format to be able to see my old friends again. And I want to thank the entire RWC community, the executive committee, but mostly I want to thank Debbie Espy, who's really the hero behind the scenes and who's really put this all together. So thank you for including me. This, I think, is one of the most exciting topics that we have. I want to tell you that there are two companies that I'll be talking about, and I don't have any financial interest in either. So at a very top level, and there's very little time for this, so I'll go through this fairly quickly and just give you the top level here. At the very top level, gene therapy really consists of three different things. You know, one is the cassette itself, which is the gene product. The others are the promoters, but the most important one that we'll talk about today are really the capsids, because that's really what distinguishes one therapy from the other. The capsids really determine the specificity and efficiency of the transfection, as well as the target site itself. The other thing that I want to say is that it's very, very important to consider gene therapy for orphan indications, as you've heard with Spark, for instance, Nightstar, and others, as a very different ball game than for chronic disease. The parameters for development, the criteria for success are entirely different of one versus the other, and we'll discuss this. So today, we're not talking about an orphan disease, but we're really talking here about a chronic disease with wet macular degeneration. And we're talking about two different companies, this REGENXBIO and Adverum. Both are involved in wet macular degeneration and now also in diabetes, but we'll confine ourselves to talking about a wet macular degeneration. So let's talk about Adverum first. I said earlier on that the capsid was really the distinguishing factor that's most important. And indeed, that's true here. This is a very special capsid. It's from David Schaefer's lab in UC Berkeley, and it's specifically designed with what's called a directed evolution approach. And this is a AAV7M8 capsid. His lab specifically specializes in designing these kind of special capsids. And this is also why he's got an entire new company that is now working with Roche for MDT. The cassette consists of what would be very close or almost identical to aflibercept or Eylea. But this is a cassette that can be injected intravitreally. And again, I emphasize it's an intravitreal approach to allow for the maximum amount of efficiency as well as specificity to deliver this product. The optic study is really very straightforward. And you can see here the patients that are enrolled are patients that have been previously treated. There's a ramp-in period with Eylea or aflibercept. Then there's the treatment, and there are pre-specified points of evaluation. What's important here is that in the cohorts I'm going to talk about, there are 4 different cohorts. The dose is a little confusing because there's a high and low, and not necessarily sequential, but very importantly, all of these patients had steroid prophylaxis. In fact, 2 of the cohorts actually had a fair amount of oral steroid prophylaxis, 60 milligrams of oral prednisone starting at day -3 for 6 days. And 2 other cohorts had topical prophylaxis for 3 weeks. So important to remember that, because one of the things that I'm going to talk about here pertains to inflammation. And remember that this inflammation occurs as a breakthrough despite this level of prophylactic immunosuppression. So here are the summary of the 4 cohorts. Again, 2 of them with oral steroids and 2 of them with a fairly extensive prophylaxis of topical steroids. The patients who were enrolled here had numerous previous injections, approximately 20 to 30 injections prior to enrollment. So difficult to treat patients. And that's seen here by the dots that are prior to injections. And this is after the injections. And to me, when I saw this, this is extraordinarily impressive. In fact, almost miraculous. It's amazing how effective this is with a single intravitreal injection. Again, I emphasize this is an intravitreal injection. If you see in this graph here, there's a 99% reduction in the high dose of necessary injections, and there's an 85% reduction in the lower dose. So as far as safety is concerned, let me jump right to the issue. The issue really here is that of inflammation. And the company will tell you that this inflammation is almost entirely in the anterior segment, is quite mild and easily handled with topical steroids. And that is indeed the case. When you look at the average number of drops, you're talking about one drop or so. However, I think the concern in the physician community as well as in the investment community is that in some patients, these drops tend to go on for quite some time, maybe over 70 weeks, and we can't identify the patients who would be most vulnerable to this kind of inflammation. I will show you the cohorts now, and what you'll see is amazing stability as far as vision is concerned and OCT. This is cohort number 1. This is cohort number 2. This is cohort number 3. And again, see the amazing stability here, both in terms of vision as well as in terms of the OCT. Here's an example of a patient that had a significant amount of fluid. Obviously, I'm going to show you a good example, so I want to be clear on that. Who had a lot of aflibercept injections, still had a lot of fluid, and following a single injection of this gene therapy intravitreal, I again emphasize a remarkable improvement. Again, this is probably the best patient in the study itself. So this is clearly encouraging. There are other studies that are going on, and this is going to continue to be further developed, but we do have to look at the inflammation part of this. Now let me switch over to REGENXBIO. And the theory behind this is a lab in the University of Pennsylvania about 10-15 years ago, Jim Wilson's lab, that really looked at AAVs in different parts of the body and realized that they weren't all distributed equally. There were certain parts of the body where the AAV were more likely to occur than others. And in the retina, it was AAV8. So this is not directed evolution, but this is specifically picked a subtype of AAV that is felt to be much more efficient in terms of the targeting as well as transduction. The cassette here produces what would be very close to, almost identical to Lucentis or ranibizumab. The study design is very much similar. There's a ramp in followed by intravitreal surgery. So as opposed to Adverum, this is subretinal surgery. This is very few selected sites with the very best surgeons, some of whom are here today, that we know. So important to understand that this is a surgical procedure with very selected surgeons. And here again, the patients who were enrolled had numerous previous injections, as you can see in the chart over here. In some, they had over 50 injections. I'll jump right to it. As far as the safety is concerned, it wasn't inflammation here related to the drug, but rather the complications, as you would imagine, from the surgery itself, despite having the very best surgeons. Very few complications, but some from the surgery itself. And again, I'll show you the amazing stability, as with Adverum, in terms of the visual acuity, as well as the OCT in cohorts 1 to 3. In some patients, they actually improved quite a bit of vision, as you can see there in cohort number 3. And again, here, the remarkable stability as far as vision, as well as OCT is concerned. I'll stop here and say that it's really tempting to cross-trial compare between these two, but it's really important not to do so. Entirely different treatments with a very small patient population. What is also impressive here is that there's a biomarker involved. You can actually measure the protein, and to give us a lot of confidence, this protein did increase in a dose-dependent manner. Not only did it increase, but the protein level stayed high for up to 2 years in some cases. So the fact that we have a biomarker that responds in a dose-related manner and stays up for quite some time should give us a lot of confidence. Again, here's the plot. And again, to me, this is really nothing short of miraculous, as with Adverum, in terms of the reduction in the number of injections that are necessary. Important to also say that the native antibodies, which may neutralize the capsid, had nothing to do with the protein production at all. So what's going to happen here? Well, this is going to go into phase 3 trial, as it should. So we'll see a lot more data. What's also very interesting is that REGENXBIO has also undertaken, with collaboration with Clearside, a suprachoroidal approach from Peter Campochiario's lab. It's been shown that the transfection efficiency with AAV8 is very good. So based on that, there's a trial that has been launched. Patients have been dosed with wet macular degeneration as well as diabetic retinopathy using the suprachoroidal approach, the design really being very similar to what I presented before. And let me end with this. As impressive as this data is, there are some questions that still remain. There are 4 that are top here, which is continuous versus pulsatile inhibitions. Is surgical administration for chronic disease really sustainable? And what about inflammation, the intravitreal, and possibly, although not reported yet, the suprachoroidal? And finally, one that's beyond the scope of what we're talking about, CMC. There are major challenges as far as manufacturing is concerned. Now, we're used to inhibiting in a pulsatile fashion. We really don't know what's going to happen when we inhibit in a continuous fashion. It may be good, it may be bad. It may be good, and we've seen some examples of this. Dante presented the port delivery system in the latter study, for instance. In some patients, they actually improved vision. Again, Genentech, to their credit, didn't make too much of this, but we've seen that with gray bug as well. So there may be a real advantage to continuous inhibition. On the other hand, there also may be a disadvantage. We've shown in preclinical studies that complement factor H may be dysregulated, so there may actually be an increase in macular atrophy. We simply don't know, and we need to find out. As far as inflammation is concerned, is the intravitreal dose, the route that's administered now, going to provide inflammation that's going to be a problem, or is it something that we can easily control? We simply don't know. And what about the suprachoroidal approach? If there's any inflammation there at all, and that has not, by the way, that has not been reported to date, then you're already in the posterior segment. Is that going to pose a problem? And finally, you don't get the inflammation with the subretinal approach, but is that really viable? Is it viable to have specialized centers and very, very talented surgeons that will only administer this in a chronic disease to reduce the amount of complications? So in conclusion, gene therapy has enormous potential. In my opinion, it's one of the most exciting fields that we have, but it also has challenges in terms of development applications that are distinctly different, and very important to understand, distinctly different for rare versus chronic diseases. And finally, and this may be the most important point, given the success of our current intravitreal anti-VEGF injections, the bar for both safety and efficacy is indeed very high. But nonetheless, I do think that this is one of the most exciting fields there is. So in closing, I'd like to thank everybody for listening, and it's really a pleasure in a time like this to see all my friends again. So thank you again.
Thanks, Praveen. That was an amazing lecture as always. We have time for one comment. I'm going to let Alan take this comment because Alan is one of the also world experts on gene therapy. You know, let's just fast forward, say 10 years. We have port delivery system. We have maybe some other anti-VEGF drugs, and maybe we have both of these gene therapy products. How are you going to decide in your patients who gets this versus something else? And I'll say that first in macular degeneration, and then maybe comment if this works also, say, in diabetes and diabetic retinopathy.
Sure. So these extended durability platforms, of course, need to consider the patient's perspective. And Dante touched a little bit on port. Certainly, Praveen did a wonderful job comparing and contrasting the potential and potential challenges of intravitreal gene therapy and subretinal delivery. Intravitreal, of course, if it proves to be safe and efficacious, will be the patient's first choice. However, it doesn't have to be, it's speaking to an in-office procedure. So suprachoroidal is another potential aspect that could be very amenable to patient preferences. We'll see. I think the translational science is really important. Again, Praveen did a very nice job showing where we could go with these technologies and what potential pitfalls will be as we travel the road.
Great, thanks. Let's move on now to Barry Cooperman, who will talk about dry macular degeneration and neuroprotection.
Thanks, Peter, and thanks everyone for this amazing conference. It's been very exciting. This is, again, a different topic now. We're going to move to dry macular, but also the concept of neuroprotection. And I'd like to echo Praveen's comments. Debbie has been awesome to help organize this, and Georges Roche as well, who is behind the scenes always organizing these conferences. So thank you, Georges. Again, by way of financial disclosure. So neuronal cell, managing this is a balancing act. Cell death is it's there. It's a natural part of our homeostasis and normalize. Various factors promote either survival or death of retinal neurons and photoreceptors. And we're always balancing these pro-death signals versus pro-survival signals, this process of apoptosis. Neuroprotection, the goal is to tip the balance in favor of cell survival. And again, if you look at cytoprotection and neuroprotection, the notion is you want to modify the activity of cells. So if you don't treat, there's progressive loss of photoreceptors. But if you do protect, then it slows it down. That's the concept of neuroprotection. Now, of course, we also use the term cytoprotection because we're also trying to protect the RPE, non-neuronal cells, as well as the photoreceptors. But there's another concept that's worth noting as well, which is neuroenhancement. So much of, I'll show you both neuroprotection and neuroenhancement. Neuroprotection, you want to reduce the rate of cell death, slow down the disease, but you don't necessarily have vision gains. But actually, amazingly, we're able to show that with some treatments, we're actually able to improve the function of surviving cells, which improves retinal function and actually gets improvements in vision in these conditions that are progressively debilitating. I'm going to focus on dry AMD and AMD-associated geographic atrophy, but it's being looked at in many different retinal diseases. And in particular, I'm going to focus very briefly on complement inhibition, integrin peptide inhibition, elamoprotide, and just a brief comment about neurotrophic products of stem cells. So we know that complement exists in dry AMD. It's been controversial. There's been a lot of failures. As we know, I'll mention briefly the C3 inhibition and the C5 inhibition studies that are underway. Again, we know about APL2, the Apellis compound. It's a C3 inhibitor, and as you can see in this pathway, it's more upstream than C5, which is what the Iveric Bio compound, Zimura, is, and I'll mention that subsequently. And we've seen that in this study that when you give either every month or every other month, these are injections intravitreally. So again, that's going to change our patient population and clinic dynamics if suddenly we're injecting dry AMD, but that is very much a possibility of the future. We can see that the data shows here, but in particular, if you look at the lesion growth size, you don't see it so much in the first 6 months. It's in the second 6 months in this 12-month trial, you see the inhibition of the GA lesion growth. So again, this is for frank geographic atrophy of this study. Unfortunately, vision is not improved in this short period of time, but again, if we treat earlier and for a prolonged period of time, the hope is that we'll save lots of vision. There was a concern in this trial with new onset exudation. It was pretty mild CNV, but it's there. And so we have to be conscious of that, whether that's going to be a rate limiting step. This may be a consequence of complement inhibition. We're still learning more about it. But there's the ongoing Derby and Oaks trials that are investigating this in the phase 3. We go on next to the C5 inhibition. Again, Zimura, avacincaptad, Pegol. The idea is further downstream inhibiting C5a and C5b. That way we inhibit inflammasome and the membrane attack complex and inhibit cell death. In this study, the GATHER1 study that was injected monthly, if you look at there were several doses, 1 milligram, 2 milligram, and 4 milligram. If you look at the 2 milligram versus sham, the 27% or so reduction in the growth of the GA lesion. And if you look at 4 milligram versus sham, there was a 27, 28, not much difference at all. The 4 milligram is actually 2 injections. So based on that data, a relatively good safety profile, that was decided to proceed with the 2 milligram dose. Again, it's well tolerated after 12 months of administration. There was no inflammation. There is, again, a low incidence of CMV, and as you can see here in the final bullet. So there is an issue ongoing there. We'll have to learn more about it in again, this was the GATHER1 trial. The follow-up trial that's going to proceed is the GATHER2 trial. And given that 2 milligram and 4 milligram were both well tolerated but had equal efficacy, it made sense to proceed with the 2 milligram versus sham, and that's what undergoing now. Rizutigimab is a very different process, and again, what I've shown you so far has been for GA and neuroprotection. Now what I'll show you going forward is more of a neuro enhancement. We think we maybe get some improvements. With rizutigimab, it's an RGD class peptide. It regulates integrin functions, and it's been shown to have anti-angiogenic, anti-inflammatory, and mitochondrial stabilization effects. And that mitochondrial stabilization may be very important for, again, enhanced mitochondrial health and therefore improvements in vision. This was an unusual asymmetric trial where the patients were given rizutigimab 1 milligram intravitreal injection at baseline and at 16 weeks, and were evaluated in the treatment arm at 28 weeks. There was a control arm which had a sham injection at baseline and then was evaluated at 12 weeks with the notion that over time you would always get worse in a sham group. So they treated it, it was a 28-week versus 12-week comparison in the treatment versus control group. Nonetheless, regardless of the study design, it was very impressive. If you looked at the primary efficacy endpoint proportion of patients with 8 letters gained, which is impressive already to think that we're gaining 8 letters, 48% of these patients gained 8 letters compared to 7% in the sham group. And if you look at the high standard of the FDA of 15 letters gained, 20% of patients gained 15 letters compared in the treatment group compared to 0 in the sham group. So here, for the first time, we're saying this is for dry AMD. This is not yet GA. This is earlier in the disease state. We're able to show improvements in vision. And this is a very new concept. We're not trying to slow down disease. Of course we are, but we're actually not only slowing down disease, but enhancing vision in this case. And so this is really quite remarkable. Again, it appears to be very safe. This is a compound that's been tested for DME and wet AMD as well. So there's been many, many injections given, well over 1,000. And again, 1,200 injections given to date. And based on this, there's a larger trial that confirms studies of this phase 2 study. So again, very exciting, this concept. Finally, elamoprotide. AMD is characterized by marked mitochondrial defects, and elamoprotide maintains the cristae architecture Again, it's the inner mitochondrial membrane stabilization. So again, it's working at the level of mitochondrion. Here's a cartoon showing how it stabilizes. It's a subcutaneous injection, so it's systemic effect. 40 milligrams subcutaneously once daily. But they looked at various efficacy endpoints, and all of them showed benefits. Low light illumination. They had two different groups, drusen as well as GA. And you could see that there's benefits in low light vision. And so based on these multitude of benefits, they're now proceeding with geographic atrophy. Again, it's the 40 milligrams subcutaneously once daily versus placebo with these various efficacy endpoints, and we'll wait and see what that shows. Just to spend one moment, even though we don't have any data yet, but stem cells, these human retinal progenitor cells, these are allogeneic progenitor cells. They're injected intravitreally in this case, and they release growth factors, so they create a healthier milieu. They've only been tested for retinitis pigmentosa. This company is J-Site, but the results have been very impressive with this. Again, when you give just single injection lasting 1 year, so this is sham versus 3 million cells versus 6 million cells, but not monthly anymore, just once a year. And for our patients with retinitis pigmentosa, this was an 84-patient trial, 7 letters gained. There was a group of patients that had a lot of difficulty in maintaining fixation, had variable results. When they were excluded, suddenly it was 16 letters gained over a 12-month period from a single injection. So the hope is that with this treatment, we can explore other things. Now, CIRM, there was a Proposition 14 in California that led to the funding of a lot of these trials, the California Institute of Regenerative Medicine, back 15 years ago or so. But now that's been renewed as of this past election cycle. So we hope to have more funding and hopefully be able to look at this in age-related macular degeneration. So again, it's a whirlwind tour. I didn't really talk about brimonidine because it's now no longer being developed. Allergan has been bought by AbbVie, and they've held off on that. But again, there's evidence of complement inhibition, integrin peptide inhibition, mitochondrial membrane stabilization, and potential future of neurotrophic stem cell treatment may be, human retinal progenitor cell may be the future for this condition. So the hope is that we will have treatments for dry AMD and geographic atrophy in the not so distant future. Thank you so much for your attention, everyone. Great conference.
Great. Thank you, Barry. Wonderful talk and wonderful summary of all of those various applications we have in the future. We have time for one question, and I'm going to lead off from the question from the audience chat. And Barry, you look at these treatments for geographic atrophy and walk us through how you might convince a patient to undergo this, because obviously they don't really see a vision benefit here like they did in anti-VEGF therapy. They lose vision over time. How do you think we're going to be able to retain patients to getting these therapies?
Well, it all depends. That's a great question, and I think we're all going to struggle with it again. This because these studies are monthly injections, is what we're looking at, or every other month for the APL2, but the monthly seem to have a slightly better effect. Though again, there's also, it's not just to complicate it. We have to also understand whether there is a risk of choroidal neovascularization that's increased. So we have to balance out the risk benefit. But I think that certainly patients that have had that have more significant vision loss in one eye are going to feel a heightened sense of urgency. I think that's going to be the low-hanging fruit. They'll be able to potentially be more enthused about treating their better eye if that's the case once we get to that point. So I think there will be a discussion. I think it will eventually become the standard to try to control their disease, and we'll have to spend some time showing patients, but it's not going to be as straightforward as it's been in the past. And I know Praveen, who does work for Iveric Bio now, is an interesting concept. Praveen, we're used to you in the community, but I know that you want to chime in. I'm not against that if you want to have some comments, Praveen.
Yeah, very, very briefly, I guess what I would say is that, look, we all realize that visual acuity is not a good proxy for visual function in this disease more than any other. I mean, at the end of the day, there's a real misconception about how quickly this disease progresses. It really matters if it involves the fovea or it doesn't involve the fovea. With extrafoveal lesions, if you just look at the lampalizumab studies, if you look at the natural history studies, the progression happens in a matter of months as opposed to fovea affecting. So you can clearly see, there would be an architect who can't see a straight line, or a bus driver that has a blind spot, or an accountant that can't read but may have 20/20 vision, but has seen this progression in a matter of weeks. Or I should say months, not weeks, but months, because it's extrafoveal, although the visual acuity may be 20/20. So I think it's incumbent on us to teach the community that visual acuity is not necessarily a good proxy for visual function in this particular disease. The community hasn't understood that, but the FDA and the EMA certainly have.
Well, that's great. So thank you for all of our speakers and our moderators for this program. Thanks for my co-chair of this program, Peter Kaiser. Happy birthday, Peter. And we're going to turn it to our diabetic retinopathy.
Happy birthday, PK.
Yep. And we'll turn over to Arturo Alexandri and Lite Wu, who are going to take us through diabetic retinopathy. Thank you.
Can I mention that this marathon may be turning into an ultra marathon at this point?
Yeah. Thank you very much.
We just took an hour and a half. You guys take as long as you want. 2-3 hours for your 1 hour session. Don't worry about time.
We have 1 minute to transfer from one section to the other section. Thank you very much for all. Was very special this section, and I learned a lot. I think all the audience learned too. Bye.
Thanks, George. Thanks, everyone.
Thank you. Bye. Thank you.
Thank you.
And we'll watch you from the other side.
So welcome to the Diabetic Retinopathy panel. My name is Lite Wu from Costa Rica. I have the pleasure of chairing this session with my good friend, Arturo Alessandrini from Buenos Aires, Argentina. We have a distinct panel with Francisco Rodriguez from Bogota, Colombia, Nari Natarajan from India, Marcos Avila from Brazil, and Mario Saravia, also from Buenos Aires, Argentina. So without further ado, Arturo, maybe you want to introduce the next speaker?
Yes, thank you very much, Lite. It's a great pleasure for me to coordinate this session with you. And I would like also to thank the Retina World Congress for allowing me to be part of this great meeting. So our first talk will be Neurodegeneration in Diabetic Mellitus by Elliot Song. Elliot, go ahead.
Well, it's a great pleasure to be with you guys at my first Retina World Congress virtually, and pleasure to speak with you. And I want to thank the organizers for this invitation. I don't have any relevant financial disclosures. As this is a World Congress, we have to recognize that clinical diabetic retinopathy is really something that everyone in the world knows about, and it's something that's really more along the lines of a microvascular disease that we're really seeing. We see diabetic retinopathy as clinically significant diabetic macular edema. We see it as neovascularization, as hemorrhage. These are all microvascular complications of diabetes mellitus in the eye. On the other hand, diabetic retinal neurodegeneration is something that's been increasingly recognized by researchers worldwide and is really gaining more attention by clinicians as well. So what is diabetic retinal neurodegeneration? Well, an example that I'm going to highlight here really shows this in a diabetic donor eye compared to a controlled human donor. So in green, what you're seeing labeled here are the NFL and GCL in these human donor eyes. And what you see is that the green layer here, the NFL GCL, is significantly thinner in the diabetics without any diabetic retinopathy compared to control. This patient did not have any signs of hemorrhage, had no history of injections or PDR or laser, and yet the NFL was significantly thinner when we looked at half a dozen diabetic without diabetic retinopathy compared to those controls. And if you look at the vessel density, the capillary density, there was no difference between these groups. So again, this is about a dozen patients split up between diabetes with no diabetic retinopathy and controls. So of course, looking at thickness, we can use OCT to really get a very good look at what the thickness is in diabetics compared to controls. Here you can see we're using some an automated algorithm that we have, the IO reference algorithms, that's publicly available. And since the last 10 years, there's been really a lot of work showing that type 1 and type 2 patients with diabetes have a thinner ganglion cell and NFL layer, even in the absence of clinical manifestations of diabetic retinopathy. You can see some of the papers here. So we did a prospective study looking at patients with diabetes, but not much diabetic retinopathy. Half of them did not have any diabetic retinopathy. The other had mild, very mild diabetic retinopathy. And the median time of follow-up in these patients was 73 months. And we looked at things like blood sugar, we looked at the duration of diabetes, and we used the Iowa reference algorithms to automatically quantify the GCL and nerve fiber layer. What you can see here in this representative OCT is how between year 1 and year 4, this particular patient without any retinopathy but diabetes had thinning of the NFL and the GCL IPL. And if you look at the rate to quantify this in these 45 patients, the amount of thinning for the NFL was 0.25 microns per year, and for the GC IPL was 0.29 microns per year. And so these changes, this thinning in the inner retina, was really dependent on the duration of diabetes, but independent of hemoglobin A1C. Now, this rate of loss of the inner retina is pretty startling when you consider that it's similar to the rate seen in glaucoma over 10 to 20 years. Now, diabetes is going to be different than glaucoma, though, because glaucoma results in focal scotomata, as well as the fact that in diabetes, it may be a more generalized thing, and you don't really see cupping per se in diabetes. But the fact that you have nerve fiber layer and GCL loss at that level is significant. So this diabetes mellitus and neurodegeneration causing significant loss of these inner retinal layers is dependent on the amount of time that the patient has diabetes, but doesn't really play a role, and it's independent in terms of its diabetic retinopathy status and HbA1c. And as I showed in donor eyes, the NFL is thinner compared in those patients with diabetes, but no diabetic retinopathy. And these eyes did not have any evidence of vascular loss. So then you might be asking, okay, so what's happening first? Are we actually potentially seeing retinal neurodegeneration before any microvascular changes, which is what we usually think of? Traditional thought is, from Kogan and others, Friedenwald, it's really the microvascular changes that are happening first. But is that really the case? So we use an animal model here with mice to actually look at this, where you have a really controlled setting where we induce type 1 diabetes, giving STZ to mice to give them type 1 diabetes, and had some control mice. We looked at, of course, at OCT at 6 and 20 weeks after diabetes, and then looked at other things as well, such as doing trypsin digest to look at acellular capillaries, looking at pericytes, looking at ganglion cells, and of course, OCT. And we used our automated algorithm, the Iowa reference algorithms, to segment this. What we found was that at both 6 and 20 weeks, the NFL GCL complex was significantly thinner in the mice with diabetes compared to the controls, as you can see here. Now, in terms of the ganglion cell density, we didn't see any difference at 6 weeks, but at 20 weeks, the diabetics did have a decrease in the ganglion cell density compared to controls. And you can see that reflected on the far right in the SCZ-treated mouse in the green layer is labeling the ganglion cells compared to the controls in the bottom right. In terms of the vasculature, we didn't see any difference between the diabetics and the controls in the acellular capillaries or pericytes at 6 weeks. We didn't see any difference in the vessel labeling at 20 weeks either, and we didn't see any difference in the retinal pericytes at 20 weeks either. But we did see neuroretinal loss starting at 6 weeks and 20 weeks on OCT, as well as the ganglion cell loss at 20 weeks. So it appears that diabetic retinal neurodegeneration can happen with no change in microvasculature in these diabetic mice. Now you might be wondering, okay, well, is it potentially STZ? There has been at least one researcher who has published on that. And so we looked at another model of diabetic mice and found in this mouse that didn't depend on STZ, but really got spontaneous diabetes in a genetic fashion, showed that indeed, even at 10 weeks and 16 weeks, that the NFL GCL thickness was less compared to the controls. So this is research that we've done at Iowa, but it's also been seen by many other groups worldwide. It's been seen by our colleagues in Europe and in Asia, South America. And so really this is something that's been seen with different kinds of animal models. People have looked at other things like peripapillary changes in the NFL GCL and found that in humans, for instance, with diabetes and no to minimal diabetic retinopathy, there's thinning compared to controls. Now, other people have also looked at other things like electrophysiologic changes. And if you look at certain things like pattern ERG, you can see that are more selective for looking at ganglion cells. You do see dysfunction of that in patients with no to minimal diabetic retinopathy. And there are visual field studies that are undergoing to really try to assess the inner retinal function. But there are many people worldwide who've done this. This as well. So what are some of the potential implications of this? Well, I think the functional impact on the retinal sensitivity is something that really is being worked on right now. It needs further research. But one of the points I want to drive home to you today is the fact that this has implications for all patients with diabetes. Again, it was dependent, as we saw in the human study, on the duration of diabetes, not on the hemoglobin A1C. So for instance, you might have a patient with diabetic macular edema who has persistent vision loss even after it's treated and the edema is gone. Now, there could be other reasons why that patient might still have vision loss, ischemia, as well as other things, but this is also something that could be considered. There's a lot of research in that's also taking place now with the neurovascular unit. For instance, does having neurodegeneration increase someone's risk for having microvascular disease? Does that come later because the inner retina and that has degenerated and that unit is dysfunctional? You know, clinically as a surgeon, I do wonder whether doing ILM peel in diabetics is something that we need to be really concerned about. And it's I think more research has to be done in this area. But if you know that these diabetics without any retinopathy are having NFL GCL dysfunction and with patients doing ILM peels. And the last thing to consider is really, should we expand what we think of as diabetic eye disease, as diabetic retinopathy? Right now, we just kind of think of it as DME, no DME, NPDR, PDR, vitreous hemorrhage, neovascularization. But there are other things that we're recognizing now that are consistent with diabetes that's not really integrated into the current severity scale for diabetes. So things like peripheral diabetic lesions, so peripheral ischemia, peripheral hemorrhages, as well as diabetic retinal neurodegeneration. So I want to thank you guys for your attention and, of course, the work of a lot of people on this and our funding sources. Thank you very much.
That was great, Elliot. I don't know if anyone of the panel members have a question for Elliot. Mario? You have to unmute yourself.
Open my phone? Okay. Let me ask. We know we have two main treatments for diabetic retinopathy. I mean, laser and anti-angiogenic therapy. It seems like laser may release some neuroprotective factors, but on the other hand, we are like in a shift going to treating diabetic retinopathy with anti-angiogenic drugs. Do you think that a sustained treatment for in the long time with anti-angiogenic may have some impact in neurodegeneration?
I think that's an excellent point. I don't think we know the answer to that yet. I think one of the things we have to think about is whether you treating someone's microvascular disease with anti-angiogenic agents might be too late. And the way I want you to think about this is, if we can potentially address the neurodegeneration, is it possible that we might be able to impact the microvascular changes that happen later? Because we certainly have seen now that there's evidence of microvascular changes that can happen before, the neurodegeneration can happen before the microvascular changes happen. So if we can disrupt that cycle, we might be able to impact microvascular disease. So what I would actually say is maybe we could try to intervene earlier, and anti-angiogenic agents might be too late. But we have to do more research to see what is the impact on the NFL-GCL on patients who are getting anti-angiogenic agents.
Thank you, Elliot. That was great as usual. So we're going to move on, and the next
I have a question, Lite.
Yeah, Francisco?
Yeah, great talk, Elliot. I have a question regarding, did you find any other associated factors that increase the neurodegeneration, such as hypertension or renal disease in the patients that you showed?
The diabetic retinopathy status did not make any difference. I don't think we looked at hypertension, but we did look at things like hemoglobin A1C. So whether the blood sugar control was very poor or whether the blood sugar control was very tight, patients still did have an increased neurodegeneration. But what did make a difference was the amount of time the patient had diabetes. So longer duration diabetes really increased the risk for a patient having neurodegeneration.
Okay, great. So moving on, the next speaker is going to be Dariana Con from Costa Rica, who's going to be speaking on biomarkers in diabetic macular edema. All yours, Dari.
Okay, wait. Thank you. And thank you for the invitation. It's a pleasure to be here. So I'm going to talk about imaging biomarkers in diabetic macular edema. I have no financial disclosures related to this talk. So to start, I'm going to define what a biomarker is. And this is a measurable and objective indication of a normal or pathologic process that we can use to detect early disease, to identify patients most at risk for progression of disease, and to develop new treatments. We have different type of biomarkers for DME and also for DR as circulating biomarkers, genetic biomarkers, and ocular biomarkers, but today I'm going to focus on imaging biomarkers. So we know that imaging modalities play an important role in deciding treatment protocol as well as for prognosticating outcomes. And imaging biomarkers provide an in vivo assessment of health of the retina and choroid in a non-invasive way. So today I'm going to talk about ultra-wide field fluorescein angiography, OCT, OCTA, and fundus autofluorescence. So to start, ultra-wide field fluorescein angiography means that we can see more than 100 degrees of the retina. Usually with the machines that we have now, we can see 200 degrees of the retina, which means 82% of the retina. And this is important because there is a significant direct correlation between DME and the peripheral retina ischemia that we can see in the FA. And also patients with this ischemia have 3.75 more times increased odds of having DME compared with those without peripheral retina ischemia. So as you can see in these images, we can identify these zones, and also we can see macular ischemia in these cases. Fundus autofluorescence, we can have the blue fundus autofluorescence and the near infrared autofluorescence, and usually what we're going to see is that this one is increased in patients with DME. And this is explained because local ocular inflammation and oxidative stress led to increase of the amount of lipofuscin and decrease amount of macular pigments in the macula. And then I'm going to focus more on OCT. We have different biomarkers. I'm going to start by DRIL, which means disorganization of retinal inner layers. And we know that the definition of this is that we cannot distinguish between ganglion cell layer, inner plexiform layer complex, inner nuclear layer complex, and outer plexiform layer. As you can see in the image on your left, there's a patient with DRIL, and we cannot identify or distinguish between these layers of the retina. And the right, you can see a patient without DRIL. And this is important that we need to measure this in the one central millimeter retina zone. And when the patient have more than 50% of this area affected, this is usually associated to worse visual prognosis in these patients. Some tips to try to identify these cases. You can preset the segmentation in OCT. Look at the OCT from the bottom up and examine the middle or periphery of the macula, so you can follow all the layers. And in the bottom right, you can see an example of drill 2. It is also important to identify this biomarker because it can be associated with outer retinal layer disruptions. It's also correlated with macular capillary non-perfusion, and it is associated with increased severity of diabetic retinopathy. Another biomarker we can see by OCT are the hyperreflective retinal foci that are defined as highly reflective dots that measure less than 30 microns. It is an imaging biomarker of retinal inflammation and a sign of hypermeability, and are usually precursors of hard exudates. Initially, this can be located in the inner retinal layers and then migrate to the outer retinal layers. The amount and the distribution of these hyperreflective foci can change after treatment, and these are important to identify because higher number of these foci can be associated to early recurrence of DME after treatment. Also, when associated with subretinal fluid, can predict poor visual function and photoreceptor damage, and poor visual outcomes in patients treated with vitrectomy. We can find these foci in all retinal layers in septus between cystoid spaces and in the outer border of the neurosensory detachment, as you can see in these images. Also, we can find these foci in a confluent configuration and within vascular walls of microaneurysms. Another biomarker that we can find in OCT are the hyperreflective choroidal foci. And these are dots within the choroid that have reflectively equal or higher to the adjacent RPE. And when you find these in these patients, they are usually associated to poor prognosis in terms of visual acuity. Intraretinal cystoid spaces that are usually present in patients with DME, they are associated with the possibility of macular ischemia when the diameter of the cyst increases. And OCT show that the cystoid spaces in the outer plexiform layer are usually accompanied by photoreceptor damage beneath the cystoid spaces in DME. Another biomarker that we can see by OCT is the subfoveal neurosensory retinal detachment that it's present in 50 to 30% of patients with edema. And we know by results from the RESTORE and the post-hoc analysis of the RISE and RIDE that subretinal fluid proved to be protective and have a protective role and visual gains at the end of 1 year. And also post-hoc analysis from the VIVID and VISTA studies show greater treatment effect when patients had baseline subretinal fluid. And usually these patients also respond significantly better with treatment with steroids. Another finding and biomarker is the posterior hyaloid membrane. We know that there is an abnormal PVD, and we can have focal and diffuse retinal adhesions that can cause obstruction in the posterior pole. And when we do surgery and remove these hyaloid, patients usually have a better outcome in DME. Another biomarkers we can measure are the retinal thickness, but this is usually not associated to prognosis, and subfoveal choroidal thickness. Usually patients with greater choroidal thickness have better prognosis because of better vascularity on the outer retina. And another biomarkers that we can see are bridging retinal processes. Usually when these are present, there's improved visual acuity after treatment. The outer photoreceptors length and the integrity of the external limiting membrane and the ellipsoid zone. Usually when we have intact IS-OS junction, we have better visual gains post-treatment. And finally, I'm going to talk about OCTA. There are different biomarkers, not only for DME, but also for diabetic retinopathy. We can see retinal vascular density, intercapillary spacing, the foveal vascular zone, and with the fractal dimension, we can see and analyze microvascular alterations and geometric alterations of the retina vasculars. You can see in image A, for example, we can see zones of capillary dropout and intercapillary spacing, and in image D, in the deep capillary plexus, we can notice more the areas of capillary dropout. And in image C, we can see an increase in intercapillary spacing. Also, we can do 3D OCTA analysis. And for example, in this study where they use different algorithms to compare, and in all of them, they found reduced retinal perfusion in patients with diabetic retinopathy in all superficial and deep capillary plexus. And specifically for diabetic macular edema, we can also see these biomarkers. We can see foveal vascular zone area, the irregularity and contour of this zone, the average vessel caliber, vessel tortuosity, and vessel density. In image A, you can see the original OCT analysis. In image B, we can see the extracted vessel map for measuring vessel caliber and vessel tortuosity. In image C, we can see the skeletal map showing segmented foveal vascular zone, and we can see its boundaries. And in image D, we can see fractal dimension image used to measure vessel density. So what has been found is that in patients with DME, there is a larger average vessel caliber, vessel tortuosity, foveal vascular zone area, and foveal contour irregularity. And after treatment with anti-VEGFs, these biomarkers can improve, but they usually do not get to normal levels. And also, as I mentioned before, by OCTA, we can see that DRIL is related to macular ischemia. Usually areas of ischemia on OCTA corresponds to areas of DRIL and on biscans. And the foveal avascular zone area in full retina, as well as superficial and deep capillary plexuses on OCTAs, are significantly larger in patients with DME compared to those without DRIL, even after resolution of DME. So in summary, with OCT, we can see microstructural details of the retina and choroid. Wide-field FA allows us to examine peripheral vascular abnormalities in diabetic retinopathy. Fundus autofluorescence has been studied recently in DME, and this may help to prognosticate and monitor the disease and response to treatment. OCTA clearly delineates the abnormal retinal vasculature in the perfusion areas, and these imaging techniques may help in the detection of the clinical disease and retinal vascular changes even before we can detect clinically changes in these patients, or even before they can develop symptoms. Thank you for your attention.
Excellent talk, Dariana. Excellent talk. Francisco,
thank you.
Which is the importance you give in your clinical practice for the OCTA in diabetic macular edema?
Arturo, I like to always check in the OCT both quantitative biomarkers and qualitative biomarkers. I like to check always the central retinal thickness, and also I like to check if there is an alteration in the interface, with the retinal interface, the presence of DRIL and the hyperreflective foci, and also the status of the external limiting membrane and the ellipsoid zone. And finally, I like to check always if there is the pattern of the macular edema, and if there is an associated serous detachment, as was mentioned by Dariana. By the way, Dariana, very good talk.
Thank you.
I have a question for any of the panelists and also to Mariana. It's how do you guys actually use OCTA in your daily practice? Do you use OCTA to really manage injections, treatment, etc.? Nutty, what are you guys doing in India?
I think that Nat is not here, Lydia. He has problems with the internet.
Okay, so maybe then we can ask Mario, how do you use OCTA for your daily day-to-day?
I was in silence because I don't use OCTA for checking my patients before surgery, but I think that I have to move on it. We have to think better about what kind of vascularization or what kind of background, vascular background we have on the patients, so we can think what are we going to do in our patients, especially thinking about MLI extraction or, but it's good to know better the kind of vascular field we are going to treat.
Daddy, how do you use OCTA in your daily practice?
I mostly use OCTA for patients with AMD, but for DME, I usually like more the OCT, the regular spectral domain OCT, to see biomarkers and decide treatment.
What about you, Marcos?
I think OCT is a very useful tool to evaluate the foveal vascular zone and see if we have ischemic areas in the central macula. And I of course, if you have no chronic cystic change, no ellipsoid zone disruption, no drill, you have a better outcome in your anti-VEGF treatment. And I think nowadays using biomarkers, we be able to realize once you have enough data, we start with steroids instead starting with anti-VEGF. That's my point using regarding biomarkers. So be precise to your question, Lee. I think foveal vascular zone, it's very important to be evaluated with CTA.
Thank you very much. So let's move on to the next speaker. That will be David Wong, and he will present pharmacological treatment for DME. David?
Thank you very much. And thank you for the organizers for allowing me to speak to this. And I've been asked a daunting task in this short period to talk about pharmacological treatment for DME and go through that. These are my disclosures. So first thing I actually want to talk about is we are physicians and really got to go back to the basics that we should be talking about systemic control during diabetic macular edema. And there's been some evidence now that lower hemoglobin A1Cs have better visual outcome, which is not unexpected. And so in the VIVID and VISTA data, we see that the lowest hemoglobin A1C quartile, they actually had the higher visual gain of 12.6 letters versus the one with the highest quartile of the hemoglobin A1C with the lower visual gain. And in protocol T, we see that for each 1% increase in hemoglobin A1C, visual acuity was reduced by 1 letter. And so it's important for us as physicians to remember to talk to our patients as well as the primary care physician to ensure that the hemoglobin A1C is lower for the future and treating of this disease. There are so many studies out there, and we look at, and there's so many treatment protocols that we looked at. But a couple that we're going to start right now are the ones with the fixed dosing, and these are the registration trials that had the fixed dosing. And we know this data quite well, and we've seen this many times over, that fixed dosing, had the same data. This is a little bit more complicated. I want to just go through this quickly. We do know that the Q8 was equivocal in visual outcomes as the Q4. What also is important is they had a rescue arm, and after 24 weeks, this be implemented. In the laser group, specifically, if they had the rescue criteria, were converted to aflibercept throughout the rest of the trial. In the aflibercept, they had laser, but they still stayed on aflibercept. And at week 100, the laser group that did not fit rescue criteria could get on a PRN dosing of aflibercept. And you can see through this data now that the drying effect is quite significant when this happened, and yet the visual acuity again did not recover, stating that the importance of treating these patients early. So let's go on to a little bit talking about individualized dosing. And in these 4 trials, I'm going to try to go over quickly. The RESTORE trial had a very interesting treatment algorithm, which is really based on visual acuity only. And when you did this in the first 12 months, the visual outcome was superior to the control arm of laser. In the extension part of the trial, which was from 12 months to 36 months, the visual acuity and dryness was maintained. Interestingly, no treatment at all was required in 19.2 patients. And you can see that this drying effect did stay across out to 36 weeks. In the RISE and RIDE in the open label extension study, patients were treated, and their treatment algorithm was including the OCT markers of activity listed here, as well as the visual acuity if it hit more than 5 letters at the month 36 level. Again, visual acuity and dryness was maintained, and interestingly, 24% patients needed no treatment. The annualized rate of injections was calculated at 3.8 injections. The endurance study is the extension of an extension study of the VISTA part of the patient trials, and their retreatment criteria was actually interesting as well, as they left it to each medical doctor for their own judgment. And you can see in the graphics on to the right there that the drying effect was maintained and the visual acuity was maintained. Again, 25% of patients did not need treatment. And in the first year of the extent of this endurance study, which is beyond the VISTA study, 4.5 injections were in year 1 and 3.4 injections in year 2. Protocol T, we know very well, and I don't want to go through it in depth, but we know that the retreatment protocol is very well defined, and very quickly we know that aflibercept is equivocal or slightly better than ranibizumab in the area under the curve the first year, and both are better than bevacizumab. The important thing to note about the retreatment algorithm is that here the DME is to be stabilized and not to resolve, and this is an important concept to know on Protocol T. Now, the Protocol T 5-year data just got released, and this is interesting to look at. What happened here is the patients were managed at Protocol T DRCR-net sites, and they're at the clinician's discretion. Patients recalled at the 5-year visit, and to their 48% of the original cohort was participating in the study, and it's essentially a review of their charts when they came back in that 5-year visit. Well, this is an interesting graph when you look at it, and again, remember the disease was managed at this point at the clinician's discretion. There's a lot of crossover of medications, not unexpected, knowing that the benefit of aflibercept and ranibizumab was superior to the bevacizumab. You can see the red down below, which is the bevacizumab. Many were converted after the 2-year mark to aflibercept, and you can see the more purpling there. And the yellow there is the visits without DME. And in essence, this is kind of the real world in the DRCR-net sites. And again, 32% of patients had no anti-VEGF treatment. Well, they maintained dryness right across the board. And you can see the all follow-up patients studied. You can see that. And then the 2 breakups of the 2 cohorts, the worst vision of 2050 to 2033 to 320, and a better visual acuity of 2032 to 2040. But the interesting part is there was a decrease in vision from year 2, but it was better than baseline. So year 5, the visual acuity is better than year 2, but better than baseline. And this is not consistent with the previous studies. And the question is why, and there may be some interesting data points we can think about later. There is a treat and extend that has also been put forth by this group and the TREX DME study, and patients were randomized to monthly dosing, treat and extend without laser, and treat and extend with a guided laser. And essentially, an extension, it was based on anatomy and a PRN in year 3. And essentially, this treat and extend was comparable to monthly dosing. So where does steroids come in? It was just brought up very earlier. Maybe this should be first line. And we can see that in similar outcomes to anti-VEGFs and pseudophakics. And protocol I in the MEAD study did show this quite nicely, that in pseudophakic patients, the visual acuity can be very well matching that of the standard of anti-VEGFs. But the adjunct therapy, there's really no visual improvement as shown in protocol U, and dexamethasone, Ozurdex versus plus ranibizumab versus ranibizumab alone. However, that the Ozurdex or the steroid did have better drying effect, but this did not translate to better visual outcomes. So with the risks we do know are the cataract progressions, intraocular increase in pressure, which is quite significant, has to be dealt with, and this was seen in all the trials. And this may be also considered as a first line, not only in pseudophakics, but maybe in patients with high-risk patients in cardiovascular disease or recent stroke. I want to very touchly briefly on the future therapies, which I think are very interesting, is the faricimab with the angiopoietin 2, which is going to be interesting, and data is coming out shortly. Port delivery system, which was talked about in the earlier session, has a potential in diabetic retinopathy treatment. The Kodiak Sciences got this large molecule biopolymer conjugate platform, which would be interesting. There's also the implant sustained release of a small molecule inhibitor, and RexGen Bio is subretinal treatment of a gene that can encode for a monoclonal antibody. And there's the anti-VEGF eye drop once daily from Panoptica. And of course, artificial intelligence or machine learning throughout this whole thing will be important in our managing and looking at this disease, not only in detecting, but potentially finding other targets and ways to deal with this problem. So in summary, the systemic control of our diabetic macular edema patients are important. Vision may be maintained on a PRN protocol, and this really does come to individualized treatment for our patients, and this could be important on a global scale. Delayed treatment does reduce visual outcome, and I think that's very important to attack this problem early, and we did learn this also through our COVID era. 20 to 30% of patients do not need treatment, and it's important to identify which ones who don't. And then again, the other flip side of that is majority of our diabetic retinopathy patients having edema have ongoing disease and need treatment. That requires regular monitoring. Future is very promising. Thank you very much for inviting and sharing.
So do we have any questions for David? Any of the panelists have any pressing questions? Marcos?
Yes, I mean, David, what do you think about long-term treatment with anti-angiogenics? My vision is we were in the RISE protocol, so now we are like 10 years after the finish of that, and most of the 9 patients we have, and they need treatment right now, and even if they didn't need it the first years. So we may think that we need to keep on treating. So what do you think about this? Or what you can say about this long-term treatment or life treatment?
I agree, and I think this is the life treatment for many of these patients. About 60, 70 of these patients do require ongoing treatment. And there's other parts of the disease we heard earlier. There's a neurodegenerative component. This may be part of the bigger picture overall. But then again, not only the diabetic macular edema, it's also the proliferative disease. Didn't have time to talk about it, but we do with these injections hold off in the proliferative disease. However, long term, many of these patients still convert from non-proliferative to proliferative despite these treatments. So this disease is ongoing, and that's why I was saying earlier the importance of systemic control, because that is really the root of the evil. Somehow to slow down the diabetic disease. But I think we're going to be treating these patients potentially for the rest of their life, for many of these patients.
David, and how you manage the diabetic macular edema?
So that's a good question. That's I think you keep treating. I don't think switching is that important. But if you're on bevacizumab, I think it is worth treating to either aflibercept or ranibizumab. And then at a certain point, when you feel it's refractive, and that's where the debate is, what is a non-responder, is to go to steroid treatment and or look at other reasons for non-responsive, such as is there a hyaloid that is taught at that point that may need removal, and that would be helpful in those situations.
Francisco, Marcos, do you agree with that?
Yeah, I do agree. I think David, thanks, David, excellent talk as always. As we all know, 40% of in this DRCRNet, 40% of the patients didn't respond to anti-VEGF. And my question is, when you're managing DME and PDR, what's your first choice? You start with steroids. It matters if the patient has PDR and also DME at the same time. Do you combine laser with anti-VEGF in PDR? What you're doing nowadays?
My days right now is I treat to quiet both the DME and to give us some time to do the laser. As much as Protocol S showed excellent data and we can inject, I think a couple of things. One was the burden is quite significant too. I have been caught like many others, some patients not showing up and they come with significant proliferative disease with traction. So now I kind of treat, if they have DME and PDR, anti-VEGF first, and then laser at the same time. If there's pseudophakics, I actually will also use steroids to help calm the eye down. If they're phakic, I do have some concerns because of the increasing risk of a cataract. And of course, also if they have glaucoma, more than two therapies, then I will be much more cautious on using steroids.
Thank you, David. That was great. In the interest of time, we're going to be moving on. And the next speaker is going to be Dr. Marcelo Saz, who's going to be talking on laser for DME. Is there still a role for that? Marcelo, all yours.
You're muting, Marcelo.
It's okay now? Okay, so thank you again to the Retina World Congress. It's a great honor to me and to the organizers, to David, Barbara, Tarek, Arturo, Jorge, and also Lita. I'm going to speak on this topic about laser in diabetic macular edema. This is my financial disclosures. As we know, diabetic macular edema is the most common cause of moderate visual loss in diabetes. The development of laser photocoagulation and fluorescein angiography ushered in the era of the culminated ETDRS. MLP was the first proven treatment for diabetic macular edema, but over the past decade, the retinal clinical trials have shown that anti-VEGF therapy have superior functional and anatomic outcomes than MLP with multiple monthly injections. So we have our two questions. What is the role does MLP play in the current management of diabetic macular edema? And is the macular laser photocoagulation is currently obsolete? As we know, diabetic macular edema is a complex combination of mechanisms of inflammation, genetic factors, systemic factors, and breakdown of inner and outer barrier. So we need an individualized treatment for our patients. As we spoke before, the spectral domain OCT classify if it's tractional or is a tractional diabetic macular edema. And if you have diabetic macular edema involving the central of the fovea, and we can classify with the fluorescein angiography is focal or diffuse, laser photocoagulation is still an effective and sure therapeutic for our patients. Long time ago, ETDRS make that what we call now the clinical significant macular edema as a combination of thickening and exudate within 500 microns from the center of the fovea, and give us the information that focal and grid laser reduce the risk of 3-line vision loss, but 50% at 3 years, 24 vision loss in the control group against 20% on the laser groups. More recently, the protocol I gives us a patient that have deferred laser group who have visual acuity compared with patients have prompt laser therapy, and 56 of I in the first macro laser photocoagulation group never received MLP treatment. As we know, a mechanism of action, the conventional laser give a thermal laser, direct thrombosis, but it can the diffuse oxygen direction from the choroid capillaries, but it have the complication that we have iris burns, paracental scotoma, foveal burns, and obviously fibrosis and enlargement of the scars. So our current objective is to eliminate the iatrogenic damage from conventional macular photocoagulation continuously. As we know, conventional photocoagulation due to cycle 100% have the powers that can damage the RPE, loss of scars span over the time, using mechanism shutters to delete energy in order to 100 to milliseconds. New technology of micropulse, it's a new technology that gives us repetitive multiple short pulse of few microseconds in duration and has the inability to observe the color change in target tissue and is useful in the subfoveal or subfoveal focal of diffuse leaks. This is called now in 2020 a selective retinal therapy. This selective retinal therapy have a lot of publications. This one from Korea and the second one from Australia, and given that this selective retinal therapy with ultra short pulse of energy in microseconds to nanoseconds selectively target the intracellular menosome or RPE, creating microbubbles that rupture the RPE without causing thermal damage of the underlying choroid capillaries, overlying photoreceptors, and internal retina. So the goal now is to confine the laser energy to target this RPE and stimulate the adjacent RPE cells to migrate and proliferate into this area to heal the disease. Another point of view is that this kind of elevation tissue temperature below the threshold of tissue necrosis leads to upregulation that we call now the heat shock proteins. And these heat shock proteins made an important role in maintaining proper protein structure and also stabilize new protein when they are properly folded. So the third question is destruction of the retina in 2020 necessary to induce therapeutic response? As we all remember, 1997, the first publication of a macular disease of micropulse laser was used not only to treat diabetic macular edema, only retinal vein occlusion, and also in some kind of corrosion vascularization. Another paper, 2009, can use in Japanese patient that make micropulse SLT MLP is effective at improving visual acuity and reducing the DME. This was a meta-analysis in 2016, and 12 months, the visual acuity was superior with micropulse laser, even though there was no change in the resolution of diabetic macular edema in the two groups. And this is a diamond trial using now in 2019 in the UK. And they are now with the NIH trying to compare conventional laser to micropulse laser in the UK. Also, there's another very interesting papers doing about what kind of spacing between the burns they have to discuss. It was a paper of Plavinsky and co-others that at 12 months, the follow-up, the group with greatest improvement in visual acuity, reduction in CMT, was the micropulse selected therapy with no spacing between burns. And also the severe of the edema can influence in this kind of technique. So this kind of technique is safe and effective when the target and the target of the CRT is less than 400 microns. What is the ideal micropulse laser? It's a yellow wavelength multi-spot technology with low duty cycle available to the 5%. With this kind of technology allows to assess power directly under micropulse mode and allows to reach the visible point. Our current settings are 160 microns, micropulse mode, duty cycle 5%, exposure 0.2, and the treatment at least 500 microns from the center of the fovea. This is our largest spot we can give. In instance, so our main indications of micropulse laser is diabetic macular edema with central macular thickness less than 400, especially in cases, and we're going to discuss this in the panel, where the anti-VEGF therapy is not available, not accessibility, in the extrafoveal macular edema without central involvement, adjuvant during the anti-VEGF therapy, or in some cases with diabetic macular edema post-vitrectomy. The burden is our topic in the very hot topic. And now we want to reduce the burden. These are two very interesting papers comparing aflibercept with the micropulse that said that in the 12 months in the paper of Abu Hussein, they reduced at 1 year, they reduced from 8.4 to 7.5 injection a year. And at 12 months also, the paper of Kanar reduced half, 5.4 to 3.4 when you compare to try to reduce the burden. What we spoke before about what's happened with the wide field angiography and the peripheral retinal ischemia. If you see the paper 2012 on Matthew and Siller-Keys, when they have a direct correlation between retinal ischemia, diabetic macular edema, diabetic retinopathy, and PRP. But now this piece of paper of Cochrane Central Registry Control Trials, and they say that at 3 years, the retinal ischemia, diabetic macular edema, the diabetic retinopathy, the ultra-wide field using the ranibizumab and PRP, there's a no correlation in what we see in the wide field angiography and the capillary closure. We have to remember the paper of Dr. Spade in central retinal vein occlusion that he differentiates between ischemic and necrotic retina, when ischemic makes a suppression of BGF, but necrotic retina, it doesn't do it. Finally, in 2020, we published our paper with Lite, Dr. Kotik, Max Wu, and Andres Hu, and we make a resume and review article of all this literature was published in 2020. And our final conclusion on this topic in laser in macular edema are: the retinal clinical trial have shown that anti-VEGF have superior functioning and anatomic outcomes in MLP technique. Modern laser are capable of producing invisible burns using this kind of technique, micropulse through threshold mode, modifying the duty cycle, or using this selective retinal therapy virtual the RPE. The best results of micropulse selective retinal therapy are obtained with central macular thickness equal or less 400. Patients we have poor compliance may be better suited to be treated to MLP, and in patients with equatorial and peripheral capillary non-perfusion, adding LLP to anti-VEGF therapy or targeting areas of peripheral retinal non-perfusion with laser does not decrease the treatment burden nor improve the visual acuity. And also, the micropulse laser obtain better visual acuity than continuous wave laser despite raise of diametric resolution. And maybe in the future, micropulse of later photocoagulation may decrease the anti-VEGF burden and deserve, obviously, for the study. Thank you for your attention.
Excellent review, Marcelo. So before any of the other panelists pose any questions, I'd like to ask you, so when do you use laser in your patients, Marcelo? Are you actually using laser for your DME patients?
That's a good question, Lita, because now we have the anti-VEGF drugs. Maybe if the patient, if we know that the patient won't be able to follow up in the treatment in the future with a good compliance, and we have a really focal diabetic macular edema with a good fluorescent angiography, maybe in that case, I use laser photocoagulation in particular situation. But we have to compare all the situations about the case of follow-up, the age, and watch very carefully the fluorescent angiography.
And what has been your experience with the micropulse laser?
Yeah, in the micropulse laser, we're beginning our first group experience. The experience is good. As we say, we can have sometimes good results in visual acuity, not always in the OCT. We see that the OCT is getting dry or thinner. We use anti-VEGF therapy. So I think it's another tool, another option to treat our patients in that kind. So now we have the conventional laser, the micropulse laser, or the anti-VEGF therapy. We have to choose whatever you find more comfortable and more safer with this technique.
Nadia, are you on, or are you still having problems? Not sure. Maybe he's not here and he's not on. So Marcos, where does laser fit in your algorithm of DME?
Lee, I think it's a very good question. Marcelo was brilliant as always. I like DME, extrafoveal DME. Sometimes we still